So we thank God that we're all here this evening. We're going to start. Thank you, everyone, for joining us in this our Critical Care Pharmacists of Nigeria Specialty Group of the Clinical Pharmacists of Nigeria, CPAN. We thank God for this day. We've been some of our clinical meetings prior to our national conference up to July. So this is the first one after our national conference. We thank God that we are here again to learn how to improve our patients' outcomes. So today, we're going to have our dear colleague, Dr. Henry Prince Osei. He's going to take us on this topic, traumatic brain injury, secondary to road traffic accidents. Okay. Dr. Henry has his B Farm B, MSc, and his fellowship in our college. He's an assistant director of pharmaceutical services, pharmacist in charge of what? Coordinator of intense training program in Department of Pharmacy, FMC. He's the immediate past secretary, PSC Bayelsa, zonal secretary, CP Bayelsa / River State Zone. He's the CPAN advisor, Bayelsa State. So our able lecturer this is highly equipped with experience. So let's sit back and listen to him. After that, there will be questions. You can send your question to the chat box, or you leave it during the question time. You can raise up your hand so that you can be identified to ask your question. So let us sit back, get your pen and paper, and listen to our dear lecturer of this evening. Thank you very much. Dr. Henry Osei, please, you can start your presentation. Thank you.
Good evening, all. Can we have the slide being shared?
Can you see the slide?
No, we can't see it.
Not yet.
Okay.
Can you see the slide?
Yes, the slide is on.
Can you?
Yes.
Yes.
Okay, good evening once more. Thank you for joining, colleagues. I appreciate you for making out time to come and, should I say, we are going to share ideas. We're going to just review a case that has to do with ICU. But before I start, I'll just give a brief on what I will be presenting. Traumatic brain injury. The patient, the case presentation is actually on traumatic brain injury, but this patient we are considering was caused by a road traffic accident. So what is traumatic brain injury? It's actually a sudden external physical assault that damages the brain. It is one of the most common causes of disability in adults, and it's described with vast varieties or array of injury that happens to the brain. It can be focal, that is confined to one area of the brain, or it can be diffuse, can affect different parts of the brain. The severity of the brain injury can range from mild to severe, which can result to coma or even death. Traumatic brain injury has some statistic in the US that each year they have about 1.6 million people who sustain.
Okay, I've logged in already.
Please, can you mute yourself if you are not, so that we can go on. Next slide, please. In the US, we have about 1.6 million people that sustain traumatic brain injury. 800,000 of those persons receive outpatient care, while about 270,000 requires hospital admission. Each year, about 52,000 deaths are recorded and 80,000 permanent neurological disability resulting from this traumatic brain injury. The financial body is enormous because it ranges from treatment to rehabilitation. In Nigeria, what is the data? We don't have data. So we're encouraged to start putting down data, recording, researching. Traumatic brain injury, of course, is a common cause of death and disability in young people too. In developed and less developed countries, motor vehicles are the major cause of death from traumatic brain injury, causing death and disability in young people. While for older people, it's from falls. As they grow old, their movements are staggered. Some of their grips are not as good as the young ones. So falls is the cause of death and disability from traumatic brain injury in older people older than 65 years. Types of brain injury. We have close brain injury. That is when you have non-penetrating injury to the brain with no break in the skull. It can be caused by rapid forward and backward movement and shaking of the brain inside with the bony skull that result in bruising and tearing of brain tissue and vessels. They are usually caused by car accident, fall, or sports. Shaking a baby vigorously too can result in this type of syndrome. So for people that when they give birth, they do some shaking, some of them will turn the baby upside down. I've seen those type of things. They shake vigorously, can cause brain injury. Then the other type is penetrating brain injury, where you have an object that penetrates or break opens the head. It can be caused by break in the skull or bullet wounds or any piercing can cause that type of penetrating brain injury. Now, there's assessment for severity. How did this injury occur? Did the person lose consciousness? How long was the person unconscious? Did you observe any changes in alertness, speaking, coordination, or any sign of injury? Was the head or any part of the body stuck in a place? Sometimes if you have an accident or something or a fall, the head or some part of the body can be stuck in such a place. It also happen in the industry where you have accident or mishap that can happen. Can you provide any information about the force? That is about the force. What hit the person? How big is it? How far did the person fall? Or was it thrown away from a vehicle or something? Was the person's body whipped around or severely jarred? All those things will tell you some level of severity or gives an impression of how severe that injury is. There's a scale that we use in assessing whether this injury is mild, moderate, or severe. It's called Glasgow Coma Scale, GCS. Next slide. That scale is graded mild, moderate, or severe based on the level of consciousness after resuscitation. Sometimes when this injury occurs, the person needs to be resuscitated. So it is the scale of consciousness, whether mild, moderate, or severe, based on the level of consciousness. Now, mild brain injury, the GCS scale is between 13 and 15. In most cases, The person may be conscious. They may be full neurological recovery. Although this patient may have short-term memory loss or have difficulty in concentrating. Moderate traumatic injury ranges from 9 to 12. The patient is lethargic, is in stupor. While severe is between 3 and 8. The patient is comatose most of the time, unable to open his eyes or follow any command. Patients with severe traumatic brain injury that are comatose may have significant risk of hypotension, brain swelling, and other complications. If this is not prevented, it can exacerbate to damage or increase the risk of death. Now, the scores is done based on eye opening, the motor response, and the verbal response. Now, if the eye opening of that patient is spontaneous, they will score the person 4. If he responds to speech, 3, to pain, 2, and if there's no response, it's 1. The motor response, if there's any stimulation and the person obeys, is 6. If it's localized, is 5. If it's withdrawn, 4. Abnormal flexion is 3. Extensor response, 2. And when there's none, is 1. Verbal response, can the person understand? If it's oriented, 5. If it's confused, 4. If he responds inappropriately, is 3. If you can't comprehend the person, is 2. If there's no response, is 1. Now, what certain things we use in diagnosis? Imaging test. We have the CT scan. It will give us a quick visualized fracture. It will give us, it will uncover areas or evidences of bleeding in the brain, blood flow, bruised tissues, and tissue swelling. The CT scan will resolve these things in a quick manner. While we have MRI, which is the magnetic resonance imaging, this test is used after the person's condition is stabilized or if the symptoms does not improve soon after injury. Then we have also intracranial pressure monitor. Tissue swelling from this traumatic brain injury can increase pressure inside the skull and cause additional damage to the brain. So physician may insert a probe through the skull to monitor this pressure. What are the complications from this traumatic brain injury? We may have cognitive deficits. We may have motor deficit. We may have perceptual or sensory deficit. Perceptual or sensory deficit. We may have issues with communication and language. There can be functional deficit. There can be social difficulties. We can also have personality or psychiatric changes. We can also have epilepsy or traumatic epilepsy. And sometimes this epilepsy can occur even after years after recovery. Now, the treatment is based on the severity of the injury. Mild one usually may just need pain reliever and other symptomatic treatment. Patients with severe injury, on the other hand, need to be given care. And most of them fall under ICU patients. There may be additional treatment to treat bleeding, inflammation, reduce oxygen supply, and that person will be placed on close monitoring. Now, the medications that are usually used are not medications that only are limited to secondary damage. The brain immediately. We may have, if the person is badly injured and they want to do antibiotic cover, we may have anti-seizure drugs to take care of seizure or any that may occur. They can also induce coma in some patients if they want the brain activities to be reduced, or if they want inflammations to reduce. When you give this coma-inducing drugs, the person is placed on a perpetual rest. So the brain activity reduced, wound healing is improved, inflammation are taken care of. Then sometimes we'll give diuretics like mannitol to reduce the intracranial pressure and to reduce fluid within the skull compartments. Sometimes it may go into emergency surgery that need to minimize additional damage to the brain. Surgery may be used to address different problems like removing blood clots, repairing skull fracture, bleeding in the brain, or open pressure sometimes. Then there may be need for rehabilitation, significant require rehabilitation. They may need to relearn basic skills such as walking, talking. The goal is just to improve the ability to perform daily activities or other tasks that the patients are used to. Rehabilitation of patients with brain injury begins with acute treatment phase. As the patient improves, a more extensive rehabilitation program is often started. The process depends on a variety severity of this brain injury, the type and the degree of any resulting impairment and disability, depending on what area of the brain is damaged and which task that area of the brain is in charge of. Then the overall health of the patient, maybe the patient is obese or the patient has some deformity before. Then also family support is very important in rehabilitation. Areas covered in brain injury rehabilitation include self-care skills, including activities of daily living, such as feeding, walking, bathing, even sexual functions, physical care, such as skincare, nutritional need, and the rest. Mobility skills, walking, self-propelling on a wheelchair, and some other mobility skills. Communication skills such as speech, writing, and other alternative method of communication. Cognitive skills such as speech, writing, alternative method of communication. Socialization skill, interacting with others within the environment, and work, vocational skills, work-related skills, pain management, that is medicine to take care of pain, psychological testing and counseling, identifying problems, solving them with thinking, behavior and emotions, family support, and education on a whole lot of training on brain injury. Recovery, most studies suggest that once brain cells are destroyed or damaged, for most parts, they do not regenerate. However, recovery after brain injury can take place, especially if the patient is young. And in some cases, other areas of the brain make up for the injured tissues, and instructions may be rooted in the brain. In other cases, brain learn to reroute informations and functions around damaged area. The exact amount of recovery is not predictable. It's not predictable at the time of injury. And we don't actually know in terms of months or years. It all depends on the patient and other factors surrounding the patient. Each brain injury and the rate of recovery is unique. Recovery from severe brain injury often involves prolonged and is a lifelong process of treatment and rehabilitation. Now I want to go to our case study proper today. Now, our patient is a 34-year-old male who was involved in a head-on collision. He is a passenger in the front seat of the vehicle. He was rushed to accident and emergency by some policemen who brought him unconscious with deep laceration in his lips and face. On examination, this patient was unconscious with deep laceration on his lips, side of his nose, on the inner center of the eye, with clotted blood around the site of laceration. Also, there was some laceration on his right forehead region. On his face, the face was asymmetric. It was swollen on the right side of the head. Laceration was on the left side of his upper lip and his right forehead. He had injury on the left eyeball. On his lips, there was deep laceration on the left side of the upper lip, and he had a fractured tooth. His vital signs, the temperature was spiking when he came. He had a temperature of 39.3 degrees C. His respiratory rate was 32 cycles per minute. The pulse rate was 100 beats per minute. The blood pressure was 140/80, and his SpO2 was 96. The assessment in emergency was that he had a deep laceration secondary to road traffic accident. He had mandibular fracture. He had a punctured left eyeball, and he was to do the following investigation: full blood count, a CT scan, and X-ray on his skull. The plan was to clean the wound, suture the laceration, and they gave him normal saline 500 ml alternate with 5% dextrose saline 8 hourly for 2 days. That was what was written on the plan. IV ceftriaxone sulbactam, that is standard, for 5 days. IM PCM 600 milligram for 4 days. And they invited the ophthalmologist to review the state of the left eyeball. The forehead laceration was sutured. The lip laceration was packed with gauze, and they did other suturing. The ophthalmologist came to review, and he reviewed both the right eye and the left eye. And the impression was that he had bilateral eyelid laceration secondary to the accident. He had left traumatic conjunctivitis secondary to the road traffic accident, and they prescribed dexamethasone, that is Maxidress, for 2 weeks. The consultant on call came to review. We can go to the next slide. It's just the consultant on call came to review and instructed that they should pass a catheter to empty the bladder because the patient was not responding. Then they should monitor the fluid input and output, and they should transfer the patient to ICU. On finding from the CT scan indicate intact cranium. The head was intact, but there was intracerebral hematoma collection, which is mostly a pool of clotted blood that forms inside the skull or the organs or a tissue as a result of the damage. And most times for this hematoma, we are talking about the brain. They had fractured left maxillary sinus with hematoma collection. The full blood count was not done as at the review. So the patient was transferred to ICU. Now, in ICU, the ceftriaxone surfactant was substituted for just ceftriaxone because the consultant felt that there's no need shooting too high. Then they added metronidazole and they gave paracetamol 600 milligrams start, and the temperature gradually dropped from 38.9 degrees C to 37.6 degrees C. The fluid intake and fluid outtake is 1,500 mils. That is what they gave him. And the urine that was collected was 599 mils. As at the point they took him to ICU, the GCS scale was 6. And any score that is below 5 is usually near vegetative state. So we prefer that it should come up. 11 and above had 90% chances of recovery. For this patient, the SpO2 was fluctuating between 95% to 97%. So the consultant felt that this patient should just be placed on oxygen. The next day, he was reviewed. The patient started having seizures. He had 3 episodes of seizure. One lasted for 10 seconds, the second lasted for 5 seconds, and the third lasted for 5 seconds. The patient was still having low-grade fever, which was measured at 38 degrees C. The fluid input and output on that day was, they gave him 2,900 mils, and he passed 2,540 mil. He was still unconscious because the GCS scale was 6. He was pale. His pupils were not responsive to light. The facial ulceration had been sutured. He was still requested to do full blood counts and differential. He was requested to do serum, electrolyte, urea, and creatinine, and was to be monitored closely. So they now commence 20% monitor, 350 mils over 20 minutes, then 200 mils 6 hourly for 24 hours. He was also given IV furosemide 20 milligrams daily, and they placed him on phenytoin 750 milligrams starts in 100 mils of normal saline over 30 minutes, then 30 milligrams daily at night, bolus for 3 days. It was used to prevent the seizure or the convulsion that he was having. Then they continued other management. He was also reviewed after then. They also still placed him on IV 5% dextrose saline 8 hourly. They used gentamicin ointment because they discovered an abrasion on his penis. The next day, they also reviewed. The patient became febrile again. He was dehydrated. There was no pedal edema, but the GCS scale has improved to 7. His pulse rate, it was 81 beats per minute. The BP was now 108/72 millimeter mercury. He was requested to do MP, and they encouraged the patient to do other tests. They also continued the patient on his antibiotic. On the 19th, the patient still had seizure for about 45 seconds, which was aborted spontaneously. The patient still received his phenytoin, but the temperature was still high, 38.2 degrees C. The BP was 130/72 millimeter mercury. He was just still placed on his medication. On the 21st, the patient's vital signs were becoming normal, but the patient is still looking ill and he was still unconscious. The pupils are now a little bit reacting to light, but it was sluggish. The patient was noticed to be making excessive urine, but at this point, I was asking the nurse what they meant by excessive urine because they did not measure. but he was still placed on 5% dextrose saline, 3 liters per day. Random blood sugar was done, and the result was 7 millimole per liter. Of course, he wasn't taking enough. The doctors were querying cranial diabetes insipidus because of the excessive urine, but it was subsequently disregarded. On the 22nd, the laceration on the facial by the maxillofacial unit. There was suture by the maxillofacial unit on the eyeball, but they noticed that there was a discharge from both of the eyes. So the impression was that he had conjunctivitis. So they placed him on GOT maxifloxacin 6 times daily for both eyes, and chloramphenicol eye ointment for both of the eyes. Patient, because he was immobilized, was placed on pressure stockings. He was placed on pressure stockings to prevent deep vein thrombosis and any other risks for blood clot that could arise. On the 25th, there was an improvement on the patient, but he was still on NG tube, and they were feeding him via NG tube on a diet of 2,000 kilocal per day. The ceftriaxone was discontinued, and they replaced it with meropenem, and they continued other management. On the 2nd of the next month, the patient started regaining consciousness. His GC scale became 10/15. He was still not speaking at that time, but he had no history of seizure, and the vitals were becoming normal. He was still on fluid diet, PAP liquid diet. He was down for possible transfer to the ward because of his improved GC skill. Physiotherapy started coming to begin to mobilize the neck using a manual therapy technique which manipulates the neck and the patient's movement around the neck. We had a discussion on meropenem and metronidazole because of this long continued administration of antibiotic, and the physicians agreed that they will review the antibiotics and stop. But also, on that day, he was given PCM, a complaint of pains thereabout. He was also given omeprazole because he wasn't really eating. Although he was fed through the tube, they felt that omeprazole could benefit the patient. They now switched the phenytoin to carbamazepine, which was given 200 milligrams at night on alternate days. They also continued with chloramphenicol eye drop, and they continued with the moxifloxacin eye drop, but they also placed him on dabigatran to prevent any blood clots that could cause deep vein thrombosis. On the 6th, they noticed a style. The nurse noticed a style, which is a red, painful lump near the edge of the eyelid that may look like a boil or pimple. So consult was sent to ophthalmology, and we had a discussion on that day because the patient wasn't really getting the moxifloxacin, so they weren't really administering the moxifloxacin. So I suggested that they should just use Cipro eye drop rather than going for a high thing that the patient is not getting. On the 8th, the patient spiked. There was temperature rise, although he was conscious, but it was noticed that the urine started having a cloudy, foul smell, and they suspected UTI. So they sent consult to the urology department. And when they came, they reviewed that they should place him on ciprofloxacin, 500 milligrams twice a day. He should continue with the dabigatran for now, pending when the consultant urologist will come. They also monitored the fluid input and output. On that day, it was surprising to me because they gave him about 3,850, and they were measuring about 4,000 mils as output. So I questioned that, why is it like this? Is it that they gave him fluid last night that they didn't monitor or they didn't measure, or what is the reason? But no clear answer was provided on this fluid input and output. He was still placed on carbamazepine. But at this point, the caregiver was now requesting that they should transfer them conscious. But the patient is still partially critical. So I encourage the patient that they should just stay for some time. And also, they said chase a water belt so that they can use it in the ward to prevent bed sores. MP was not done, so the consultant just treated empirically for malaria. He gave Lonadiaz because of that temperature spike. Yet, they were not able to also provide the IV omeprazole that was prescribed. So the consultant from urology said they should do urine MCS. His SpO2 was stable, physiotherapy was actively ongoing, the neck mobilization was going. There's also tactile stimulation to check if there's any damage with those aspects. Manipulation of the joint too was done. Now, the impression for the ophthalmology unit, he said that he had conjunctivitis that was resolving. The upper eyelid, at the left eye, there was a localized collection of cells, usually produced in response of an infection. So they still say you should continue with his good maxifloxacin. At that point, we had replaced with ciprofloxacin, so I said they can give. But he also insisted that they should get tobramycin ointment to apply and move the patient to surgical ward so that the cost will reduce. But the consultant urologist also gave tablet nitrofurantoin. Remember, the urine bag was collecting with frothy urine that was smelling. At this point, on the 19th, the fluid input and output, they gave him 2,320. They only collected 600 mils. I believe that this fluid input and output was not properly done. They also request daily full blood counts. Physiotherapy was ongoing and it was vigorous because the motor response, according to him, was falling, was not as good as he thought. On the 21st, the patient caregiver complained that he had not passed stool for the last 4 days. Although the patient was still on NG tube, through which pap was given with glucose and milk and other things, but the GCS scale was still 10/15. They assessed that the patient was having constipation. So the plan then was that they should blend fruit rich in fiber, the cucumber, watermelon, pineapple, and they should give him that blended fruit. They also prescribed rectal bisacodine. Then he was encouraged to take adequate fluid intake, that is water, fruit juice, and other things. They also continued the management. On the 22nd, there was no new complaint. The NG tube fell out. but patients was told to be fed orally if you can tolerate. If you can't tolerate, the NG tube should be passed. They requested for serum electrolyte test and continue management. It was recovery on the 23rd. Vital sign was stable, and the serum electrolyte, urea and creatinine was yet to be done. At this time, we'll continue with our ciprofloxacin eye drop taken orally. We'll continue with our dabigatran, carbamazepine, and tobramycin eye ointment. The nitrofurantoin was discontinued, and he was encouraged to do other tests. Patient started passing stool on the 24th. There was no new complaint, and they retrieved the serum electrolyte, urea and creatinine tests. The values were normal. The ophthalmology reviewed there's granuloma on the left upper eyelid, which was getting bigger. So there was plan to excise when stable enough to be, they should move the patient to the eye theater and to excise it. They continued the tobramycin at the left eye, and they removed suture on the upper left eyelid. At that point, he was taken to the surgical ward, and at the male surgical ward, and the pharmacist at the surgical ward took over. Although I went there to visit severally to see that he's recovering. He was recovering fine. Now, pharmacare, what were my goal? To ensure that there was proper use of all medication, because there was barrage of medication being given to the patients. He was placed on a lot of medication and were needed to make some input. Some of them was not able to get at that time, but we could wriggle our way to get some of the medication to ensure that the patient recovers from coma and wound heals with no complication. That should be no complication. Prevent further complication. Then the plan, what is my plan? Provision of medication and ensuring the patient gets medication, which was done every day I visited. Prevent drug therapy problem and ensure rational use of drug. Ensure clinical symptoms are resolving. Daily monitoring of wound to ensure wound is healing. Ensure seizure is controlled. Prevent further seizure. Ensure adherence to medication and therapy. Drug therapy problem, sometimes there's non-adherence, like our moxifloxacin was not available for a long time until we suggested that Cipro should be used, which was sourced easily. And I feel that there's additional therapy. This patient, I discussed with the physician, he came bleeding. They did not transfuse, they didn't put in on hematinics. And at some point, it was pale. Then fluid therapy was not properly managed. I discussed this over and over. We didn't understand ourselves on this. And there's need for us to do some education of fluid management or therapy. Unnecessary drug, like when it came to A&E, he was just given Tandac and sometimes moxifloxacin, although the argument here is that moxifloxacin gives them better results. Intervention, ciprofloxacin was suggested and was procured, was used. Patient relative was encouraged to procure drugs and do investigation. They were a little bit slow because of financial constraint. Physician was educated on the need to do proper fluid therapy and follow hospital guide. We discussed in A&E. The hospital should have guide for things you give. When you see a patient, do you start from the high-falutin antibiotics and the rest? And we had that discussion, and I think they appreciated it. Hematinics was prescribed in surgical ward eventually. Pharmacist challenge, especially in ICU, consults were not promptly responded to. And because of the barrage of different consultants coming, sometimes You just have to make extra effort to talk to them. Patient did not carry out required tests sometimes at the appropriate time. Empirical treatments were also given, may lead to treatment failure. Solution to combat long-time use of medication in ICU. Sometimes even the nurses stop abruptly on their own because of the long-time use. Now, what are the outcomes of this MyPharmaCare? Clinical outcome: symptoms were resolving, wound healed, the GCS scale improved from 6 to about 10 and eventually regained consciousness. In surgical ward, they weren't measuring the GCS scale. Fever resolved, seizure was controlled, and the patient was doing well. Humanistic outcome: the caregivers were happy with the therapy they got. Additional note: we mentioned cranial diabetic mellitus, which I call extra food. It's a rare condition characterized by excessive thirst, that is polydipsia, excessive urination, that is polyuria. It's not related to the common DM, where the body does not produce or utilize insulin. It's a distinct disorder caused by partial or complete deficiency of the protein arginine vasopressin, which is required by the kidney to regulate urine production. It's a common form of diabetic insipidus. It is caused by damaged hypothalamus or pituitary gland following an infection or a brain tumor injury, and that's why they were suspecting diabetes insipidus. These are my references, and thank you very, very much.
Thank you very much. Thank you very much, dear presenter. Do I stop sharing the slides? I should stop.
You can keep the slide in case there's a question.
Okay. Thank you very, very much, Dr. Henry. I just want to summarize just few sentences. We just showcased to us traumatic brain injury. I started earlier by giving us a brief summary of what TBI is all about. He informed us that we have a focal, it may be focal or it may be diffuse TBI. He went further to say that we have different types, and also there's, for now in Nigeria, we don't have data in case of the epidemiology of this disease state in Nigeria. He informed us that we have two types of TBI, the closed one and the penetrating brain injury. Okay. He informed us on how to assess the severity of these patients. Okay, it depends on the patient GCS in question. The patient lose consciousness immediately, and how long was the unconsciousness, and so on. Okay, he informed us that the GCS that it's used to scale the level of consciousness of the patient, it may be mild, between 13 to 15 of 13 to 15 T. When it's moderate, the GCS should be between 9 to 12 T, then severe between 3 to 8 T. At that point in time, the patient should be in coma. Okay, and at that point in time, there's bound to be hypotension, hypoxia, brain swelling. That's, we use eye-opening, motor response, and verbal, to check the patient GCS. For diagnosis, we can use CT scan, MRI to recognize what was really wrong with our patient's brain injury. Then complications are many of them: cognitive deficits, motor deficits, so on and so forth. Then for the treatment, he mentioned that it based on the severity of the injury, that we can use anti-seizure drugs, coma-inducing drugs, diuretic, and surgery as the case may be, and other measures like rehabilitation, family support. Okay, so he now enter into case study of our patient, that's 4 years old male. So the case is a long case. I wouldn't want to start to explain the case again, it's self-explanatory. So at this point, I want us to start to ask questions. I want it to be interactive. It must not be our presenter that will answer the question. If you have the correct answer or have more information to put to us, the essence that we want to learn on how to manage traumatic brain injury patients in any type of scenario where we need them, especially in the ICU. So it's time for questions. You can raise your hand or you write at the chat box. I can see one hand on. Dr. Waneka Bademashi, you have the floor.
Okay, thank you, sir, for a wonderful presentation. In fact, it was very exciting and well articulated. You know, maybe I missed something. You talked about hematoma.
Yeah.
That the patient had hematoma, and I was wondering how that hematoma was addressed. Okay.
Okay.
Because I was listening to, hear how that hematoma was addressed.
Okay. He had that patient was the hematoma was handled by the ophthalmologist. He had that blood clot around the fractured eyeballs.
Okay.
So they did some procedure to remove the fluid and the blood clot around there and did suture. And that's why at some point he had also infection there. The hematoma that they found in the patient there, when they did the scan, they thought that the hematoma was internally, that is in the brain. So they were concerned that that could lead to further damage. But when the ophthalmologist came, he said that what they were actually seeing was as a result of the fractured eyeball. So he did a procedure there and collected the fluid and the blood clot around there, and that was it. The rest was just they just gave 20% mannitol for the raised intracranial pressure. He was having convulsion. At some point, even I was suspecting that is there no possibility that this patient still had collection of blood in the cranium? But of course, there was no other scan that confirmed that there was blood clot in the brain. So it was just treated that way. And it continued. I think it was only the ophthalmologist that did a procedure that collected clot around the eyelids. That means to say that.
Okay. Okay, because that means maybe probably only cranial inflammation. That
yes.
Okay. And then another thing is, what's the nursing position? Because usually when they have a cranial pressure, the bed is pulled up at the head so that they will be slanting, and that slanting position also lends, kind of augments what the mannitol is also doing.
Yes.
Pressure, okay.
Yes, in the ICU where they had this automated bed.
Okay.
They use it to do all those
network is
elevated shunning that they did here. Renal pressure. Can you hear me?
Yes, I can hear you now.
We can hear you. We can hear you.
Yeah. There was this automatically heard.
Okay, thank you very much. Thank you very much for this answer to this question. Okay, I can see many more hands on. Let's from DAE ask his question. Please, after you have finished asking your question, please, can you bring down your hand?
All right. Okay.
DAE
Yeah.
can have the floor.
Yeah. Good evening. Can you hear me? Okay.
We can.
Okay, that was a very wonderful presentation. Even though I never knew it was going to start by 8, I thought it was the normal 9 p.m. My name is Emmanuel, though I work in a community. I practice in community in pharmacy. So my question is, using that dabigatran, which is a novel anticoagulant, I don't know, did they do the NIR, that's International Normalizing Ratio? And I believe, apart from the deep vein thrombosis that they were trying to prevent, probably because of that hematoma. But my question is, did they do INR? Because this medication too can also cause hemorrhagic stroke, or they just gave it based on the assumption that, okay, this will take care of the clots and also to prevent deep vein thrombosis. That's my question. Thank you.
Yes, actually, in fact, I actually asked that question. If you can, if you earlier followed this presentation, you will see that this patient is not too financially buoyant. In fact, what the doctor wanted to give was to give heparin.
Yeah, exactly.
There's more risks with heparin, so he prefers dabigatran.
Okay.
So that it will reduce that risk of any hemorrhagia.
Okay.
So this patient is not financially buoyant, and that's why they didn't do INR for the patient. Because even the normal routine test they requested for ECU, MP, they wasn't able to, at some point, they weren't able to do it. So they just gave, based on it was a long immobilized patient. So the physician, their assessment is that the benefit outweighs the risk for now.
Thank you very much. Can I throw more light? Can I add something to this?
Yeah.
Okay. For me, the protocol we have in ICU, most of our patients are non-ambulatory, right? So the protocol is to start anticoagulation therapy as fast as possible. For us in our own center, within the next 48 hours, that patient must be on anticoagulation therapy, except when it's contraindicated. For this case scenario we have now, the CT scan was querying hematoma. So that was why they couldn't initiate it early enough. When he came into the ICU, but mind you, he was on a compression stockings, and this will still help to prevent DVT. It's a non-pharmacological measure, right? Okay, and for the INR is one of the clotting tests we do, clotting profile, but it will help us to know the idea of our patient clotting profile. But you can remember that we don't use INR to monitor dabigatran. So it's good that we do it if the patient can afford it. But in most cases, for these patients, once it is established that there is no more risk of bleeding, it's good to initiate anticoagulation, which they did much later with dabigatran. That's my contribution.
Okay, that's your field.
So we have another hand on. We have pharmacist Ola Ononka. Please, can you ask your question? Thank you.
Yeah, okay. Good evening, all. Thank you very much for the wonderful presentation. I have a number of observations and I would like to be cleared on them. The first one is on the issue of the GCS of 6/15. I'm just wondering, GCS of 6/15, but the patient was never mechanically ventilated, because with GCS less than or equal to 9, from 9 downwards, patient has no control over their airway and they need to be ventilated. You need to protect the airway. And most times they ventilate them mechanically. And also ventilation also helps to rest the brain so that whatever is happening, the recovery can take place. So I'm wondering, why didn't they ventilate the patient? That's one. Then two, like you said, clotting profile was really necessary. I don't know, in the center where I practice, they don't wait for patients. I don't know, that's our style. They don't wait for patients to pay to do tests. We just run tests and keep running tests. When they're about to go, you can now pay. So we all those tests must be done, and they're usually done. So the clotting profile was really very important. Then I also want to know, at what point did they introduce the dabigatran, in the sense that did they rule out any possible bleeding in the skull before adding the dabigatran? And another thing, why the choice of dabigatran? Because in ICU, first of all, the most times in my center is enoxaparin, Clexane, that we use before. It's only when the patient gets a lot better before we can now step down to any oral anticoagulant. And then with dabigatran, you don't use INR monitoring unless I'm wrong. I think it's warfarin, you use INR. Because I know with Clexane, you can do with the heparin, it's APTT, you monitor. Clexane, I think, is the PT, you monitor. I'm not sure, but I don't think dabigatran will use INR. Then, okay, those are the ones I can remember. I don't know if Then, hey, you said something about the fluid, that you weren't sure why the fluid was output was so much and then input was small. In the ICU, sometimes is most times when patients come during fluid resuscitation, they get a lot of fluid, and so their input and output, most times they may be retaining. That's why fluid balance may be positive for some time, and then towards, as they're getting better, it's actually good for it to be negative, so that they're moving out the fluid that they've accumulated in the course of the resuscitation that they had while in the ICU. I guess that's part of what was happening to this patient. So it's a good sign. It's not a bad one, unless it's too much. Unless the patient is pushing out too much fluid, then they'll suspect some issues. Okay, so I think those are the ones I have for now. Thank you.
Yeah, thank you very much. Your center may be better than my center. My center, you have to pay for a test before it's being carried out. And that's why I talked about, they wanted to use low molecular weight heparin, which is the Clexane, at some point. The patients then, they were considering there are a lot of cost consideration for this patient, which personally I wasn't comfortable with, because you have to really treat, especially for a patient that is not conscious, is unconscious. They were waiting to take a safer option. That's why they gave dabigatran, which does not actually require so much monitoring using INR. So that's why the dabigatran came later. Although they did compression for input, Stokins compression to prevent deep vein thrombosis, and did some other precautionary procedure for him so that it doesn't have deep vein thrombosis. But of course, any patient that is long on the bed, conscious like that, he should be given anticoagulant to ensure that there is no deep vein thrombosis. For this patient, wasn't placed on ventilator. I'm not even sure if that ventilator is in good shape. What we was giving was just giving oxygen. They placed oxygen for him, and they continued with oxygen. Wasn't really placed on the ventilator. So that's it for this patient. But I believe we would have benefited from ventilation, ventilator, to say. So thank you very much.
Thank you, Samuel. I hope you are cleared.
Actually, when you're suspecting that a patient has, we are talking about traumatic brain injury, okay?
Yes.
If there are a in the brain, you don't, then that aggravates the bleeding in the brain. And, you know, kind of trying to reduce the volume. That means the person has to go through brain surgery, okay? So their caution about not adding it ab initio is according to guideline. I don't know whether I'm taking it too far.
No,
okay, until they were sure, until they were sure that there was no bleeding in the brain. Because if there had been, just like when you have CVA, that is that involved hair, so you don't apply it immediately until you are sure that will not come up with that danger of bleeding in the brain. Then you can use other means. So since there were maybe not enough either patients will not be able to pay for all that is needed to ascertain all these things. So the heparin or whatever that they delayed a little bit is according to guideline.
Okay.
Even if they were not following guideline, but that is very good.
Thank you very much, Dr. Bonemacho, for this more light to this question. Okay, can we have Pharmacist Agada HOP? Your question, please.
Okay. Thank you very much, Dr. The presenter for job well done. Among the drugs were used, you mentioned phenytoin, which was later replaced by carbamazepine. And both drugs are enzyme inducers. I don't know whether because of their nature, being enzyme inducers, there was any consideration in the adjustment of other drugs that were used, or it wasn't necessary?
No consideration was made. Actually, they were having the needed results from other drugs, so there was no consideration made for enzyme induction or for if those drugs would be broken down faster. I think if that has happened, then they may have increased the dose or would have suggested that another drug entirely would be used. So I don't think that was that consideration. What they were trying to do is to control as much as possible seizure in the patient. And for the carbamazepine, they use alternate days instead of every. So that one also gave a better outcome in terms of enzyme induction or using other drugs to be broken down faster.
Okay, thank you.
Okay. Now, can we have Pharmacist Ifeoma Moma? Pharmacist Ifeoma Moma, you can ask your question.
Hello. Hello. Good evening.
Yes.
Go ahead.
Yeah. I just have very brief observation. Before I do, I want to appreciate the lecturer and the people that asked me, whether they were asking questions or they were also the lecture is so noted. I really learned. It's not a question, just an observation. The time mentioned about reading, the person was patient. First something about nutrition, and I now noticed that at the end of the lecture, when you were talking about outcome, you didn't mention anything about the person's nutrition. Whether there was then a pharmacist intervention, there was nothing said about nutrition. I'm just looking at it that nutrition being a key something in critical care, and the fact that we have our practice, we are expanding, we are growing, we are going places. I feel that maybe in your center, maybe you don't have nutrition pharmacists, maybe, I don't know, but I'm just saying that I was looking forward to seeing, something about nutrition towards the end, and it was just silent. Nothing was said, except if I'm mistaken, but there was nothing was said about improvements, challenges, outcome, nothing. So it'd be nice if it would have been nice if it was included, or it would be nice, for future presentations. You remember we have nutrition pharmacists in our midst, so want to really feel very, very well represented too. Thank you very much.
Thank you very much. I was expecting that question because they gave this patient blend of fruits and the rest. In our center, I think we really don't have a nutrition pharmacist for now. I don't know. Although we've had one or two persons that had trained and talked in that direction, but we've not had a very developed nutrition inputs here. But we still have nutritionists that we can call if the patient needs nutritional advice or food and therapy like that, especially if the therapy is based on nutrition. For our diabetic patients, most times they call them to do all sorts. But for this patient, we really did not have any nutrition input as pharmacists for this patient. Except if we have any other person that could have mentioned anything that would have benefited this patient in terms of nutrition. But we really did not have that input, especially for this patient.
Thank you very much. Timmy Pray, you have questions too? If you can raise down your hand. From TB, go ahead with your question.
Yeah, thank you so much, Dr. Henry Osai, for this wonderful case study presentation. Thank you. It was really a wonderful eye, opener. My question actually is directed to pharmacists, former MOMA. You talked about nutrition, and you were trying to say doesn't mean that our center doesn't have a nutrition pharmacist. I want to ask you, because I know I don't know, does your center have, and then in a case like this, what do you do? That's what I wanted to know. And also I want to ask Dr. Maureen Nwafo, who is also has been a critical care pharmacist all this while. In your center, I don't know, because when you talk about nutrition, is there anything you could do there for this kind of patients to assist as a pharmacist? But I would really like to first hear from pharmacist, from our MOMA.
Let me answer before Dr. Morris says anything. No, she's the expert in this area. In my center, we don't have nutrition pharmacists per se. It's just that I've been in a nutrition pharmacy group. I would have loved, there to be a better, will I say, more wholesome, in the way he flowed down to when he talks about challenges, when he talked about, okay, no, so far they didn't have that as a challenge, no problem. But he mentioned outcome, you understand? He mentioned intervention. So I was, hoping to see something about nutrition there, maybe later. That was why I said it. It's not like we have, but I'm in nutrition pharmacy group. So, in ideal setting, we should have, but we don't have. So when you hear people talking about their center, you want to see like theory. I know it's not good enough, but you want to know more. Do you understand? That was why I, voiced out. I would have wanted to, hear more. So I'm not even yapping that they don't have. I'm not saying that maybe, is it because they don't have? I didn't see that role really play out in his presentation, especially towards the end, the summary. Do you understand now?
All right. Thank you.
Thank you very much, Vanessa. For me, yes, I want to say that
I understand you, but please, I know that when
continue. We are not hearing you well. It's like your line is breaking.
I know that
Okay, thank you very much. Two of you, your lines are breaking. You can't hear what you are saying. Can we go ahead? I did not.
Oh. Should I go again? Should I? Hello?
Just summarize what you want.
Hello?
Ify, can you summarize what you want to say, please?
Okay, I said, she's asking whether we have in my place. And I said, no, we don't have. And that was the more reason I spoke up. Because I heard when he mentioned about feeding. But towards the end of the lecture, I didn't see much about nutrition at all. He didn't mention anything in the challenge or in the intervention or in the outcome. So I was wondering, is it because they don't have nutrition farmers? I would have, loved an opportunity where we are better represented and maybe get more. So, I was thinking about, I was expecting to hear maybe what will be the challenge or the outcome or anything, but he did not say much there. So it's not because we have, we don't have, and that's more reason I would have wanted to know how an ideal or a better place that has, all those specialty pharmacies will, carry out such duties.
We get your question.
Answered that they too don't even have that. If they have any challenge, they will call on the nutritionist. Definitely, what he means by nutrition is somebody that's not a pharmacist. I don't know whether
if we get your yes, we are good with what you're saying. I want to explain this. Critical care pharmacists have a great role to play in terms of nutrition.
Okay, thank you.
You don't have to wait to have a pharmacist specialize in nutrition. If we have it, that's fine. But once you are in critical care, most of our patients are conscious. they don't feed through the mouth. Most of them feed through the NG to be sometimes not even feeding at all, as the case may be. So we should be able to assess our patient nutritional status. Very important. Yes, it's our duty to do that. So we should key into it. Don't wait until you see somebody who specializes in nutrition. For us in our center, we assess our patients. In most cases, we start them with fortified pap when they are ready to take into the N2. Fortified pap means that there is carbohydrates, there are proteins, fortified, right? But for these patients, I don't think this patient needs extra nutritional services except this normal fortified pap. And you can see he informs us on regular serum electrolyte tests, they're all normal. So there are no electrolyte challenges, and the patient continues to improve. And he initiated even oral medication. So he's feeding in terms of little food they can give him. When they mentioned about the food, is when he started having constipation. So they wanted things that would help him to move bowel. But my observation is that they didn't get it on time. It's still our duty to always look at the charts, because in my own center on daily basis, if our patient moves bowel, it's written. So we have captured it on time and initiate the Bisacodyl or anything on time. Then adding the fruit is fine. It wasn't be yes, it wasn't be a nutritionist that will say it's our duty to look out into those things and prefer solution. It's only way there is need for TPN that will now need to have a specialized pharmacist. But still, we in critical care still go into that. So, and I encourage all of us to look into these nutritional services for our critically ill patients. Thank you very much. Can we have our dear, wow, I didn't even know, wow, former PSN Deputy President, Dr. Dan Orunwese is in the house. So we are glad to have you in our midst. We are blessed this night. He's even raising his hand. Wow, please, can we have you, sir?
Thank you very much. Good evening, everybody. And thank you, Maureen. I love what you are doing, and I believe that we're on the right path. Thank you very much for this opportunity. My contribution to the presentation made so far, particularly with reference to the last observation concerning nutrition. Let me first and foremost say that these presentations are actually kind of peer review presentations. Want to call them peer review because practices from one center to the other may not exactly be the same, simply because the lead clinicians hardly ever refer to even the national standard treatment guidelines. I happen to know that because I know that there's a new national standard treatment guidelines that talks on a lot of disease conditions and how you can treat them, first line, second line, and so on and so forth. That's one. Two, in every treatment, there are usually two angles to it, particularly when it comes to monitoring. The laboratory tests or the investigations and the clinical observations of the treatment giver, that is the physician, who is the lead person in this case. And what I have seen so far is that the lead clinician actually involved many of his colleagues in areas that were of concern to him or beyond his own area of competence, which I think was a very good thing. And then the second part is that the pharmacist who took it upon himself to look at this critical care patient also did a lot of work in trying to examine what was done and what is supposed to be done and the outcomes. I am happy that he mentioned that the patient did not move his bowel for about like 4 days or thereabouts. And that is because he was also in touch with the patient's relations who were available. And of course, were able to talk to him because he was able to open a line of communication between himself and those people, such that if they had any concerns, they believed that probably when they told him about those concerns, he will be able to relate them appropriately to the other people who are concerned with the care. So basically, I'm very, very happy that this has happened. I didn't even know that this was going on in my own backyard where I was pretending over. But I'm very, very happy that it's coming from my center. My center is a growing center. We have an ICU. I don't know how much of it if you compare to other ICUs, but I do know that there are a few gadgets here and there. And let's not forget that in ICU, the only permanent residents in ICU are the patients and the nurses. And of course, when you talk about nursing care, you talk about you bring in a lot of issues that border on attitude. The nurses on the morning shift may not be as friendly as the nurses on the afternoon shift. The nurses on the afternoon shift may be more lackadaisic than the ones on night duty. So unless you are able, from time to time, that you go to check the charts and bring it to the notice of whoever is on ground before some things are done. You know, we live in a society where people like to pass the buck. The only time they are concerned is when they are involved or somebody very close is involved. But I wish the reverse was the case. Now, I'm also of the opinion that there is no ideal center in Nigeria in terms of what we do because of the quality of people that we have. You find the same people who do the work in the public hospitals are the ones who also run to the same private hospitals to provide services. So this is one area that we really need to look at in assessing what we do and what the outcomes are. I am very, very happy that you chose this topic, which has to do with a bit of a diabetes insipidus, which is a very rare case, and that the patient was able to come out of the coma from Glasgow coma scale of 6 to 10. I think that was very commendable, and of course, it was not for too long. Now, in terms of TPN, which is total parenteral nutrition, I think TPN becomes very critical if there is no way the patient can be fed. But in this case, the patient had a nasogastric tube and it was being fed. And I think that the clinicians who were monitoring were satisfied with the outcome in terms of the nutrition, the nutrition and whatever it was getting in terms of calories. And I think they also tried to measure the quantities that were given and whatever it was that was the output. Now, in terms of specialization, this is also an eye-opener for many of us here now on which areas that we want to go. Critical care is very, very important. It's not only for medical emergencies. It can also be something that insidiously develop and eventually become a medical emergency, as we have seen in this case. I am sure that this patient was not too observant enough to observe that certain things were not going right until he fell into the situation that he found himself. But in any case, we're happy that the patient was brought to our center and the center was able to take care of him and he came out of the situation and is alive and will go back to his family. In a nutshell, the things I want us to understand is that caring for patients is not only enough in terms of laboratory investigations. There are sometimes that the clinical situations are opposite of what the laboratories are churning out. And you can see this in so many cases, right? And of course, again, if you go to the laboratories, only God knows what goes on there. And because you don't have direct you do not have direct supervision over what goes on in the laboratory. You just have to understand and take what their results are. But again, if their results are not in consonance with the clinical observations, of course, you now begin to raise eyebrows. And that is the reason why there's some kind of disagreement between med lab scientists and, of course, the medical doctors who take the lead in the patient care. Again, it also brings to the fore the multidisciplinary nature of healthcare. The multidisciplinary nature of healthcare. you will find that in this case now, the major roles for the pharmacists were like that of a bridge builder between the caregiver, between the practitioner, the patients, and the nurses. In fact, everybody who was involved with the patient care, one way or the other. And all the drugs he was able to provide. So I really want to say thank you, Dr. Henry, for taking this initiative. And thank you all of us for being here. And thank you for those who have raised concerns. And of course, we hope that many of our pharmacists will now begin to look beyond certain areas and let us begin to look at things like total parental nutrition as part of our roles. Let's begin to see how we can collaborate more with even the nutritionists and the dietetics, with the medical personnel, with the nurses, and so on and so forth. Now, the barrage of medicines that we are prescribed. Hello. The barrage of medicines that we are prescribed. Yes, I want to summarize. The barrage of medicines that we are prescribed were as a result of the number of persons who saw. Many of them just wrote something down because they needed to write something down. And that was why you saw that maybe some of the medicines that they were writing, because they did not ask questions. How can somebody be prescribing moxifloxacin that is rare, and meanwhile there is ofloxacin and ciprofloxacin that will do the same and is more available? So these are some of the things that we need to do. So what I'm saying in effect, and my conclusion is that we have done well, and let us keep doing it. And let us have at the back of our mind that this program that we're running is more of a peer review thing. So that what we do in our center, others will learn from it. What are the positives we take, the negatives we point out, so that when next we are confronted with them, we're able to do better than we have done in the previous case. Thank you very much for listening to me. And I want to thank you because you have given me this time to talk. Thank you very much. God bless you.
Thank you, our dear fellow. I'm not surprised. Well, you've been there all through. Your wealth of experience cannot just measure. Thank you very much for your contribution. And for me, I want to list some of the observations I have here. It will help us in any center you find yourself. From this case, I found out that ICU in that center, they don't take care of our patient in terms of antibiotic stewardship. If you look at how the antibiotic was changed from tetraazole to meropenem and forward and backward nitrofurantoin, and I've not seen him mention about culture and sensitivity tests. You know, yes, they can start empirical, but when they even when they notice colored urine, I think there is need for us at that point at least to do urine culture or something like that. So we must should step up in advancing our prescribers the right way to manage antibiotics. So antibiotic stewardship is a very good protocol that we should have in our various ICUs. And I noticed that the protocol for managing total brain injury was not really adhered to in this case. In all ICUs, once patient come into the ICU, there are certain drugs that should be in that patient prescription. This patient should have initiated a stress ulcer prophylaxis at least the next 48 hours or so, but they did not do that. They later did that days later. And after that, I noticed that still the patients cannot afford to get the omeprazole, and no intervention was done. So stress ulcer prophylaxis is a protocol that must be adhered to within 48 hours of patient admission, because they're under stress. At the initial point, that when the GCS was so low, that patient is on stress, and his pain is another factor. And nutrition was not that good, so we must have to cover his GIT. So it's a very big gap I noticed in this presentation. And another one is anti-seizure medication was not initiated at the right time. Once you have traumatic brain injury patient into the ICU, the protocol says initiate anti-seizure prophylaxis even when there was no history of a seizure, because in most cases, seizure will come up. So we should initiate the prophylaxis early enough. But in this case, it was not initiated until seizure ensued. Before they announced that they even started with monotherapy and they continue to increase. So the right protocol in managing TBI is to initiate prophylactically the anti-seizure drugs. So in my center, we start with the phenytoin. Before you know it, that patient may not learn to show seizure symptoms until after the management. But some cases, even if with the prophylaxis, seizure may still ensue. Some may even come in with seizure already. Okay, at that point in time, we'll step it up to 3 different anti-seizure drugs. We use Keppra, phenytoin, diazepam, as the case may be. So it's very, very important that we pharmacists should point it out. They should initiate it. We shouldn't wait until our patients are having seizures. One there's issue with the brain, especially in TBI. So I noticed that too. Okay. And in terms of our patient couldn't afford money to do certain tests, it's a very big gap. In intensive care units, it cannot manage patient without labs. It's not possible. Laboratory is critical in managing critical ill patients. Though this one was not on ventilator, it's supposed to. Maybe it wasn't. I don't know. Other tests I was expected to see, like arterial blood gas, I didn't see it. You know. So for us in our center, we now have ICU lab just very close to the intensive care units, outside the general hospital laboratory. But at this point, we found that still that lab not even meeting our goal because it's somehow PPP. You know, so for now we don't have another lab inside the ICU. There are certain labs where the patient have the money or not that must be done for the clinicians to know what they're doing. So it's a gap too. So you should take it out with your management to fill this gap. But they can't just manage such ill patients blindly. Okay. And another thing, our able senior colleague, Dr. Dan Orunwese, he said that it's only nurses and patients at the permanent residents in the ICU, and I don't think I believe with that statement. Critical care pharmacists are still one of the permanent residents in intensive care units. Yes, that's the right situation. Because once drugs are being given in that ICU 24/7, there should be a pharmacist within the complex. That's the right scenario, the right environment. So the pharmacist should be there 24/7 and should be located within the complex, not just far away and be coming in, peep, drop the drug, go back, no. So I encourage all the centers to make sure that their pharmacy unit is within the ICU, and they must have 24-hour service. Night pharmacists will come in the night, in the morning others will continue. So we are permanent residents in intensive care. That's the right way to go about it. So that's it. I pray that after this presentation, we go back to our various ICUs and encourage them for us to bring out protocols in managing certain types of disease, like this TBI, like a standard protocol guideline in managing. So it will help everybody to know what to do day 1, day 2, day 3, so that everybody will know this is what should be done. So once they are being deviated, we can call ourselves to order. So I just have one question to ask our dear presenter. You inform us about the coma-inducing drugs. I want to be sure is what I meant. Please, can you just throw more light and tell us what you use in your center to induce coma? Thank you very much.
Thank you very much. It's just a protocol. for inducing coma. I've not seen a patient that they did it, but we've had a discussion even with the physician. The coma-inducing drug, most time it is still the normal propofol, phenobarbital, taupental. It's still all those drugs that they use in inducing coma. It's usually done by the anesthetic. So most time, it's a rare procedure or a rare technique for patients that maybe they have inflammation in the brain, or they have some type of trauma and they need to make the patient calm or reduce brain activity for the patient to recoup. It's like telling the patient that is in a state of trauma to rest so that the body can recoup, or so that treatment can go on in such a way that it doesn't harm the patient. So those coma-inducing agents, they are not in the normal protocol for ICU patients because most of them are comatose. But sometimes they use it to induce coma in order to treat. So it's our normal taupental, phenobarbital, and the rest. So it's not drugs that are unknown to us.
Oh, I now understand. Thank you very much. For me, it's like it's because of the words you use. If that you use the CNS depressants, that would be, we would have catch on immediately. So I'm wondering, how can we induce coma? The essence is they want to depress the CNS so that the patient will become, and the brain will become to heal. Thank you very much. I still have one more hand, and after this, we have to call it a day. I want to thank everybody that's really joined us today. Within the week, we're still going to bring in another one case study on our platform, and we're all going to discuss it. And by next month, there will be another presentation by one of us.
Hello.
Okay, can we have Elias says please?
Hello.
Go ahead.
Okay.
Elias says.
Yeah, thank you so much, Dr. Harry, for a very wonderful presentation. Although I came late because I thought the meeting was to start by 9 o'clock. I was mistaken, and I regret, not joining on time. Having said that, I want to ask Dr. Morin, the guideline you're talking about in your center, is it possible for us to share your guideline in UNTH? Because I know in UNTH, they have a standard ICU having operational, which is known to us. And I also want to ask Dr. Harry, do you think that we can, establish the presence of pharmacists more in ICU, in FMC Yenegua? Because it appears the pharmacist is not resident in the ICU in FMC Yenegua, just like any other center. And that's reflected in when Dr. Dan was talking about the issue of pharmacists not be present in the ward. I mean, the ICU. Is there any way we can improve pharmacist participation in centers like FMC Yenegua? Thank you very much.
Yes, thank you, Pharmacist Eze. The ICU in FMC Yenegua, we've actually made moves to have a place where we have to be residential in. But for now, we've not been able to achieve that objective. It's not also as developed as the one in Enugu, where Dr. Morin is practicing. In fact, their own ICU and some form of procedure, including the open heart surgery and other things they do, is much more developed there. For us, we are still trying to get as much, should I call it, acceptance for us to have a space there. And our ICU is actually small. It's not as big as other centers that I've seen. In fact, even the doctors, they really do not have a place, so to say, beyond the room where they change and gag and wear some form of protective gears. We don't have so much space in our ICU, but I believe in the future we should be able to advocate for pharmacies being residential there. Another thing about that ICU is that most times their protocol is quite different from a normal ward that you can just throw in, throw out. So they also require you to wear some of their protective gear. You don't go in with your shoes. They have some protocols. You wear some type of things so that you don't carry other extraneous materials into the ward. But for now, we've not had a place, and I believe that maybe in the future, they'll be able to provide a space for us, or we'll be able to push our way in, or they will have some level of collaboration that will make us more residential there. If you see the one in Enugu, you may be jealous. Just as the HOD has said, Dr. Dan, he said, it's a developing ICU, and I want to leave it as that. Thank you very much.
Thank you, Dr. Henry. Elia says that please we'll continue this talk after the presentation. You can talk on WhatsApp concerning what you did for me. Okay, so we are going to talk this.
Please don't forget the slides. We would love to have the slides. Thank you.
Okay, we're going to share it. I hope you are with us on our platform, Critical Care Pharmacy platform. If you are not there, please chat me up to add you to the platform, but we are going to continue with a case study. This
okay, please, your name, please.
I'm from Maureen.
Okay. All right. No
so chat me up so I can add you to the group. Okay. Thank you very much. I don't know how I want to appreciate our dear presenter, Dr. Henry Osei. Thank you very, very much.
Thank you,
I'm very
ma'am.
happy to have you this evening. Enough your time to educate us on TBI. I want to appreciate our dear former Deputy President, Sir Dr. Dan Oriwese, for gracing this meeting this night. So we are pleased to have you. I want to recognize my boss. Wow, my dear boss, Dr. Waneka Benemasho. Anything you are seeing in me, I got it from her. I'm so glad that you're here this night. Though you've retired, but you are still not yet tired. Thank you very much for giving me the opportunity to learn under you. I'm forever grateful to you, ma. Thank you for joining us this night.
Welcome. Welcome. You're a good I don't know.
I'm highly I don't know how to pay you back. She gave me an environment to learn and to showcase
seeing you move on, develop, add on one more gives me joy.
Thank you. God bless you. You are a rare pharmacist to find. I'm so glad. Thank you very much for your support. So that's the continuity
Thank you, ma. So thank you very much, ma. God bless you, ma.
Yes, yes. That's how it should be. Please, let's try to mentor. It's very, very important. Anyway, I see Dr. Waneka Benemasho, I feel so happy. All our training outside the country in the US was from her. She pushed it. She was our boss. She even went there with us.
It's enough.
I don't know where to start. So my God bless you. Please let's start to mentor the younger pharmacists. That's the way to go. And I'm very glad to inform this house that one of the pharmacists I'm mentoring is in the house, Mrs. Rosemary Naman. If I'm not there in the ICU, once Rosemary is there, I'm covered.
You're covered.
I'm not shaking.
Yeah.
But she has learned it. So please, let's try to mentor our younger ones. We are not going to be there forever, so that we continue to have pharmacists in various fields of pharmacy practice. So on this note, we are going to end this presentation. I'd like to see all of us next month. Thank you once more. So can we have a closing prayer? Can somebody volunteer?
Okay, in Jesus' name.
Amen.
Father, we thank you for an enlightening moment. Thank you, God, for strengthening our arms in this wonderful profession. Our prayer, oh God, is that we will never disgrace you and disappoint you in the name of Jesus.
Amen.
For all the vessels that you used to build us up this evening, we pray, oh God, that you continue to build us up until we are able to be who we are meant to be in this pharmacy profession. In the name of Jesus.
Amen. Thank you. Enjoy your nice sleep.
Good
night. Good night. Thank you.
What do you tell them? I don't know. If someone was telling me, I don't know. That's how I discovered that the key is not going with me. That's why.
Yeah. Not the wrong one.
Forget, maybe tomorrow. Your story is too long, I don't have time. I just reply.
It's good to like natural things. Oh, my father and I make the salt just put up pot. From the plant. From the container. From the container. From the plant. When the corn is done, you put salt. Right, last piece. You put it immediately, you put the corn. You cook it for 12 hours. You know, as you're looking at the corn, remove that thing from your mouth. No salt. Now the salt. Yeah. Stop. The salt that you are taking is no longer. I was